The idea here is that we want to modify T cells, cells of the immune system, to attack cancer cells. T cells could kill cancer cells, but they don't because they don't see the cancer cells. So we collect T cells from each patient. We genetically modify their T cells using a virus. That allows the T cells to express a new protein. That's called a CAR, or a Chimeric Antigen Receptor. That protein drives an interaction between the T cell and the cancer cell, and two things happen. First thing happens is that hopefully the cancer cell gets killed. That's what we're shooting for. But the other thing that's also very important is the T cells then get an activation signal, and they grow, they proliferate, they increase in number. At ASH this year, we're updating a large phase 1/2A study in pediatric ALL. We've treated now 39 patients. And these are all patients with relapsed refractory ALL. 2/3 of them have already had a bone marrow transplant, and that bone marrow transplant didn't work for those patients. They relapsed. And so in that group of patients, many of whom had refractory disease responding to nothing, we collected those T cells, we gave them their T cells, and a month later we assessed their response, and 36 out of 39 of those patients, or 92%, are in a complete response a month later. That's the first important finding of the study. Now we're able to say, since we've been at it for a couple of years, how the durability is. And so what we're able to say is that 70% of the patients that we treat remain without any recurrence of their leukemia, the vast majority of which did not undergo transplant or any other treatment at 6 months. So 70% event-free survival rate at 6 months. Excitement right now is in ALL. We're excited that there's a pediatric focus to the current drug development plan, and I think the other thing to mention is the fact that we now have a multi-site phase 2 pediatric study sponsored by Novartis that's now going to see if we can roll this therapy out to other centers.